Good evening, everyone, and thank you for joining us tonight for Illinois Bone and Joint Institute's 22nd Virtual YMCA Education Series program with the North Suburban YMCA. My name is Karen Brownlee, and I'm a personal trainer and the Adult Program Coordinator at the NSYMCA in Northbrook, Illinois. Tonight's program, entitled Understanding Rheumatic Diseases, will be hosted by Dr. Teresa Sosenko. Many people have heard of rheumatoid arthritis, but what that is and what other ailments fall under the auspices of rheumatic diseases remains a mystery to most of us. Rheumatic diseases are autoimmune and inflammatory diseases that cause our immune system to attack our joints, muscles, bones, or organs. Rheumatology treatment can help with common symptoms such as fatigue, worsening pain, recurring pattern-like pain, joint abnormalities, loss of range of motion, joint dysfunction, and other conditions that seem to have unknown origins. Common rheumatic disorders include osteoarthritis, rheumatoid arthritis, lupus, ankylosing spondylitis, psoriatic arthritis, Sjogren syndrome, scleroderma, and gout. Tonight, you will learn more about the causes, symptoms, and treatment options available for rheumatic disorders from IBJI rheumatologist Teresa Sosenko, MD. Dr. Sosenko completed her medical degree at Poznan University of Medical Science in Poznan, Poland, and her residency in internal medicine at Tri-Health Good Samaritan Hospital in Cincinnati, where she served as chief resident. She then went on to pursue a fellowship in rheumatology at the University of Illinois, Chicago. Dr. Sosenko grew up in Joliet and is an active member of the Ukrainian community. Outside of her medical practice, she enjoys staying active by playing tennis and golf, as well as snow skiing and participating in water sports. She is also an avid baker and specifically enjoys baking pies. Yum. Dr. Sosenko says rheumatologic disorders can be quite challenging to diagnose and require a sound foundation in internal medicine, critical thinking, and attention to detail. As a rheumatologist, I approach each patient individually and develop a treatment plan that is evidence-based and best tailored to my patient. I firmly believe in and encourage open discussions with my patients as part of my team approach to patient care. Rheumatological conditions are often chronic. I look forward to long and meaningful relationships with my patients and delivering the best patient-centered care. Thank you again for joining us this evening, and thank you, Dr. Teresa Sosenko, for your time and effort in putting together this presentation to teach us about rheumatic diseases. Now, Dr. Sosenko, please take it from here.
Awesome. Thank you so much, Karen, for the warm welcome. This is just a general outline of some of the topics that I'll cover today. We'll cover just briefly the history of rheumatology, what exactly we do as specialists, and when you should see one. And then we'll just go over briefly some of the most common rheumatologic conditions that we treat and that we get consulted for. So just some fun facts. I always like to start my presentations with a little bit of history. So rheumatology dates back pretty far to about 1500 BC times, where it was first described in the Ebers Papyrus, which is considered to be kind of the original literature of medical literature, almost like the first textbook. Later on, the term rheuma, which is where rheumatology comes from, first appeared in the literature. And it was referred to as substance that flows, and that's why they believed that these rheumatologic conditions could flow to different parts of the body, causing systemic disease. And later on, it became known to be a systemic disorder. And in 1928, our sister committee, the American Committee for American College of Rheumatology, now as it's called, was founded. And then just a few years later, the terms rheumatology and rheumatologist were coined and became more commonly used. So what is a rheumatologist? A rheumatologist is a physician who specializes in the diagnosis and treatment of diseases, typically that affect the muscles, the bones, the joints, the ligaments, and the tendons. We also treat a group of, diagnose and treat a group of diseases called systemic autoimmune diseases. We also refer to these as connective tissue diseases. And these are more of the typical autoimmune conditions where the immune system just is not working properly and attacks the person's own body and causes inflammation. And some of these diseases, such as lupus and Sjogren's disease, and a lot of these systemic diseases can affect any part of the body, including the eyes, the lungs, even the blood vessels, the kidneys, etc. So how are we trained? So we typically do medical school followed by a residency. you're an adult rheumatologist, you first go to an internal medicine residency. If you're pediatric rheumatology, and then you do pediatric residency first, followed by a rheumatology fellowship. And we do consider pediatric and adult rheumatology somewhat different. The diseases that we treat, the pediatric rheumatologists treat, are different than when we treat. We as adult rheumatologists typically will see patients over the age of 18. So these are just some of the conditions that we treat as rheumatologists. The list is very expansive, as you can see here, just some of the common ones that Karen had mentioned: lupus, rheumatoid arthritis, osteoarthritis, gout, fibromyalgia. We also deal with a lot of just patients who have chronic joint pain, back pain, etc. There are over 100 to some even say up to 200 diseases that we are able to treat. So this is just kind of the most commonly seen ones. So when should you see a rheumatologist? It is very often for patients to have intermittent joint pain. It is common, especially as we get older. One of the concerning things is if you have pain that involves multiple joints, and there's always a concern, is there an underlying systemic disorder? If you all of a sudden develop this acute joint pain that was not associated with any injury, that also makes us wonder if there's some sort of inflammation under there. If you have joint pain that's worse in the morning, or if it's accompanied with fever, rash, chest pain, we want to make sure you don't have anything like lupus or rheumatoid arthritis, etc. If you have joint pain that's associated with back pain, in particular a lot of stiffness, we see a lot of patients with psoriasis who develop joint pain because one of the conditions we treat is psoriatic arthritis. Oftentimes if patients have new pain or weakness in their muscles, we're often consulted just to make sure that there's no sort of disease of the muscles that's present. And also, one of the biggest things to take home is if you're over the age of 50 and you develop new headaches and muscle aches that are persistent, you should consider seeing a rheumatologist because there is a disease called polymyalgia rheumatica that is more common above the age of 50. And then oftentimes we're consulted if, the team just does not know what's going on. If a patient has these ongoing symptoms such as fevers, weight loss, etc., we're often consulted to see if there's some sort of underlying autoimmune process that's going on. Here are just some general risk factors for rheumatologic conditions. These are broad risk factors, and we'll narrow down, a little later when we get to talking about some of the more specific diseases we treat. And these general risk factors include smoking, excessive weight, genetic factors. A lot of our diseases do have a genetic component to them, and then certain occupations and increasing age. Just some general symptoms of rheumatic diseases, and this just may, have you think if I should see a rheumatologist, and this is persistent joint pain. If you have a lot of tenderness around certain joints, if your joints seem inflamed, and inflamed joints we mean is there swelling, is there redness, are the joints very hot to touch? If you've noticed any sort of joint deformities, and if there's loss of range of motion or decreased functionality of those joints. And then also if you have a lot of fatigue, just a lot of drainage related to the joint pain, we want to make sure that there's no underlying inflammatory cause. So what to expect at your rheumatology visit? A lot of our diseases are very complex. Oftentimes they're very challenging and they do require multiple visits to diagnose and to get down to the bottom of it. We perform a complete medical history and physical exam, especially in rheumatology. Family history is very important because, like I had mentioned, a lot of our diseases, there is an underlying, family tie. Oftentimes we review prior tests if they've been done, and oftentimes we do have to order additional lab tests, specifically some of these specific antibody tests that need to be done, and imaging study if that's needed. And after that, we put all the pieces together, and that's essentially what rheumatology is it's putting all the pieces together of your medical history until we can come up with some sort of game plan. How common are rheumatologic conditions? It's estimated that up to 1/3 of the US population has some sort of rheumatologic condition, and that's anything from osteoarthritis, which is the most prevalent by far out of all of these conditions. Both genders are affected, however, women typically have a much higher risk, and that is even more specific for some of these systemic autoimmune conditions. And lo and behold, chronic musculoskeletal conditions are the leading cause of disability in the US. So it is a pretty big healthcare burden to us that does require, good treatment. So moving on now, I'm just going to move on to some of our common conditions that we treat. I'll start with osteoarthritis. So just as a general background, arthritis is a general term that means inflammation of the joints and pain. There are different types of arthritis, and this is important for us as physicians because we want to know if a patient has just some sort of osteoarthritis, which in general term means wear and tear, or is there some sort of inflammatory or autoimmune process going on, or even some sort of infection. Like I mentioned before, osteoarthritis is by far the most common type of arthritis. So what is osteoarthritis? And you'll hear me use the terms OA and osteoarthritis interchangeably throughout these next few slides. It is a slowly progressive joint disease. It is typically seen in the middle-aged to elderly patients. It is the leading cause of disability, and it's estimated that up to a third of the adult population has osteoarthritis, and most people know someone in their family that has arthritis. And as we get older, the incidence does increase. So what exactly happens in osteoarthritis is that the cartilage that's between the bones in the joint spaces themselves tends to break down. It's very often in the joints that do most of the work and bear a lot of the mechanical loads, for example, in the knees, but it can be seen in anywhere. And we'd like to categorize it in a few different ways. There's primary arthritis, and you can think of patients who have just knee arthritis, or there can be patients that have generalized arthritis. They just have a lot of arthritis everywhere, in the back, the knees, the hips, etc. And then there's what we call secondary arthritis, which is some patients may have some sort of other disease that predisposes them to have osteoarthritis. And what are some risk factors specifically for osteoarthritis? These are, age is the strongest risk factor that is associated with OA. Also, if you have a family history of osteoarthritis, your risk is much higher. And this is especially prevalent and especially true in patients who have what we call Heberden and Bouchard nodes, which are bony deformities of the hands, which I'll get into a little later. Women have a higher risk of osteoarthritis than men. Obesity, smoking, if you've had any sort of prior joint trauma or injuries, and also certain occupations. And these are occupations that typically involve, for example, if you've been a construction worker, done a very physically tasking job, or if you do something with repetitive motions such as sewing or knitting or computer work. And also joint deformities such as unequal leg length, if you're bow-legged or not, because that does put undue stress on other joints. A common question that we get is, how does obesity predispose to osteoarthritis? And this is a very important topic in osteoarthritis, and we're blessed to have ortho health at Illinois Bone and Joint. As the weight of a patient increases, so does the load of the joint, and that is especially common in the lower extremities. Our joints are only supposed to do so much. And oftentimes patients who are overweight, they do tend to have poor posture, and that also puts some undue stress. And adipose tissue, which is also called fat tissue, does also increase the inflammation. That can make pain worse. And I always like to tell my patients that by just losing 10% of your body weight, you can cut your arthritis pain in half, and that is a significant amount if you think about how much some of our patients have to deal with. And here are some of the more commonly involved joints in osteoarthritis. The hips and the knees are very common areas, as well as the neck, the back, and also the hands. In particular, the hands, we think of the base of the thumb and the further joints, which you can see here on the figure. The base of the thumbs is extremely common. We see that quite often because if you think about how often you use your thumbs, it's almost in everything that we do, and it does lead to some overuse there. When patients have osteoarthritis, they most typically have joint pain, and this joint pain is usually worse with movement, and that's opposite to patients who have inflammatory arthritis, where they actually feel better when they're moving around. They can have stiffness. There is something called the gelling phenomenon, meaning when they go from an inactive position or immobility to start being active, they feel very, very stiff. And sometimes they can have swelling of the joints. Oftentimes we see patients who have OA of the knees, and they come in and they just need their knees repeatedly drained. And oftentimes patients can hear what's called crepitus, or cracking or grinding noise, and that's very common in the knees as well. And over time, it can lead to just decreased functionality of the joint itself. So how is osteoarthritis diagnosed? So initially, it does require an evaluation by your physician. Oftentimes we can get a good idea based off your history and based off the exam whether or not you have osteoarthritis or if there's a concern for some sort of other arthritis. And imaging is very important. Oftentimes we start with x-rays and advanced if needed. And sometimes other lab tests are needed just to make sure that there's nothing else going on that may cause another type of arthritis, such as gout or rheumatoid arthritis, etc. Just one common overlooked cause of knee pain, and this is especially important in our patients who have osteoarthritis. A lot of people have what we call pes planus, which is flat feet. And this, to most people, may think it's nothing, but when you lose the architecture of your foot, it does put undue stress on the knee, and that can lead to osteoarthritis. So that's why when you are at the doctor, it is very important to make sure to have your feet checked as well and to see how you walk, because a lot of the pain and the functionality can be improved just by simply wearing orthotics. This is another common question that I receive. Patients come to me with hand deformities, and they want to know if this is rheumatoid arthritis. So fortunately, no. These are called the Bouchard nodes and Heberden nodes, and it's just named after the people who found them. And these are signs of osteoarthritis. These are what we call osteophytes. They're just kind of these bony growths. And it's particularly common at what we call the DIP joints and the PIP joints. These are much more frequently seen in women, and there's a familial tendency. And if you've noticed that your mother had these similar deformities, there is a very good chance that you will likely, you may develop these. And sometimes these can lead to a little bit of deformities. Most of the time they're painless, but sometimes they can be painful. But this is a sign of osteoarthritis. So the million-dollar question is, how do we treat osteoarthritis, and is there a proven treatment? Unfortunately, there's no treatment that medical science has developed yet that can reverse the damage that we have. The goal of treating our patients with osteoarthritis is to reduce pain and improve function. Some of the most important things is exercise and physical therapy. We always say that the movement is grease for the joints. And like I had mentioned before, weight loss is particularly important, especially in those weight-bearing joints. In 2019, the American College of Rheumatology actually adopted some new guidelines, and they actually in those recommended Tai Chi, which I do recommend to a lot of my patients. And then when we talk about more of the medical aspect, anti-inflammatories, whether they be topical or oral, but you should always consult with your physician before starting any of these. And if those conservative measures fail, we do oftentimes give our patients injections as needed. And there's also the use of bracing and even certain types of taping, which is more useful in the knee as well. And then optimal footwear as well is very important. So now moving on to rheumatoid arthritis. So rheumatoid arthritis is very different from osteoarthritis. On the contrary to osteoarthritis, which is a wear and tear arthritis, this is what we call an inflammatory arthritis, meaning there's a lot of inflammation in the joint. It is the most common type of autoimmune arthritis. It affects about more than 1 million Americans, and most of these patients are women. It is a chronic inflammatory disease, and patients do need to be treated, usually for the years to come. And it usually begins between the ages of 30 and 50. It can't start at any age, though. However, we do have patients that present at age 70 to 80. We also have patients who present much younger when they're teenagers. So it really varies, but most of the time it begins between the ages of 30 and 50. So what causes rheumatoid arthritis? This exact cause of RA, and I'll use the terms RA and rheumatoid arthritis interchangeably, remains unknown. It's thought to be multifactorial. The immune system, just like in other autoimmune diseases, does not work properly. Our immune system is meant to defend the body, but in certain disorders, it kind of goes haywire, decides to attack, specifically in rheumatoid arthritis, the joints, which leads to inflammation. And long-term joint inflammation can lead to damage of the joints, which is what we try to avoid. There also are some genetic factors. Studies have shown that there are certain genes that are passed down, and there is an increased tendency, if there is a family history, for a patient to develop RA. There also are some environmental factors. Smoking to this day is the only modifiable risk factor that we have to reduce the risk of rheumatoid arthritis, which is pretty significant. And there have also been some studies to suggest that bacteria, particularly in the gut and in the mouth, may have some sort of causative role in rheumatoid arthritis. But the biggest take-home point here is that smoking really is the one thing we can do, anyone can do, to decrease their risk of rheumatoid arthritis. So what are the common symptoms of RA? So just like osteoarthritis, patients get a lot of joint pain, but the biggest takeaway is patients have a lot of stiffness. They may wake up in the morning and they can't use their hands. They can't grip the cup that they used to grip. And there's a lot of swelling. And typically as the day goes on, their stiffness improves and their joints start to feel much better. And one of the biggest complaints we have is that patients say they're no longer able to wear their jewelry or their rings. And with that, with the swelling and the inflammation, that can also lead to decreased movement of the joints. In patients with rheumatoid arthritis, and contrary to patients with osteoarthritis, there can be internal organ manifestations. It can affect the lungs and different parts of the body, which I'll briefly mention next. And just as with any sort of systemic disease, patients can also have loss of energy and appetite. They may also sometimes lose weight if their inflammation is very active. And some patients can also develop what's called a secondary Sjogren's disease, which they may develop dry eyes and dry mouth. So here are just some brief things that I just want to show you that, as you can see on the right, the chest X-ray, there is the patient with rheumatoid arthritis who clearly has lung disease. The elbow on the left is what we call rheumatoid nodules. Some patients with rheumatoid nodules rheumatoid arthritis can develop these nodules. They can also get inflammation in the eye. And the biggest takeaway is the top left and the top middle, and that is what we try to prevent when we're treating rheumatoid arthritis. And we want to prevent damage to the joints, and we want to prevent these irreversible deformities. So how do we ultimately diagnose rheumatoid arthritis? So just like a lot of our rheumatic diseases, there's not one single test to diagnose rheumatoid arthritis. A lot of our diseases are like puzzles. It requires a lot of testing, a lot of diving deep into your history to figure out exactly what's going on. So we really take the history and the review of systems, very seriously. When we examine you, we like to examine every single joint just to make sure that there's no synovitis or what is considered inflammation in those joints. And family history is also very important. We want to know if there's any some sort of autoimmune arthritis in the family. And social history, particularly if you have smoked or do smoke currently. And then after that, we go on to do some of our labs, and we do have some specific tests for rheumatoid arthritis, but we also do the basic tests, which also help us to determine if there is some sort of chronic disease going on. And it really does help us define what treatments you'll be able to use down the road. And imaging as well is also important for a few reasons. One is to get a baseline of patients' joints, but also to track their treatment, and if we have some sort of diagnostic uncertainty. So how do we treat rheumatoid arthritis? Unfortunately, to this day, there is no cure for rheumatoid arthritis. But modern science has been excellent to us, and we do have many excellent options. Most patients that are treated do have good or excellent relief, and they can live fully functional lives, and they do live, relatively normal lives. The most important thing, though, for rheumatoid arthritis is to start medicine as soon as possible to prevent these joints from having lasting or even permanent damage. And the biggest takeaway with rheumatoid arthritis is there is no one size fits all. Oftentimes our patients, you need to switch therapies. Sometimes we need to add on therapy just because, each body tolerates something differently. And we do have a lot of different options, like I mentioned. Typically for patients having flares, we may start them on anti-inflammatories or corticosteroids, specifically prednisone or Madrol. And then what we like to start is disease-modifying agents, and these are medicines that patients are on for some time to come. And this is really to prevent damage to the joints and decrease the inflammation that is usually not only in the joints, it's in other parts of the body. We also have a lot of new biologic therapies, which I'm sure everyone has seen on TV recently. And as we speak, we do have new treatments that are emerging. And besides medicine, exercise, diet is very important in rheumatoid arthritis, and the social history. And just to point out, just to hone in again on the fact that smoking is very important, and physical and occupational therapy, as well as just patient education and knowing what's expected and what their disease course should look like and hopefully will look like. And this is just briefly what I talked about, that there are big differences between osteoarthritis and rheumatoid arthritis, where osteoarthritis simply is just wearing away of the normal cartilage of the bone, whereas rheumatoid arthritis is an autoimmune process. A big question I also get is there a particular diet for arthritis? There have been some studies lately that have shown that possibly a Mediterranean diet, in particular for rheumatoid arthritis, may improve the inflammation and improve functionality in patients. This has been seen in only just a few studies, but something to take a point. We always like to tell our patients that anything in moderation is the way to go. Now moving on to another very common disease that we treat, and that's osteoporosis. So what exactly is osteoporosis? Osteoporosis is a disease that causes the bones to lose their integrity, and in such they become thinner and weaker in structure, and that predisposes patients to an increased fracture risk. And up to 40% of women with osteoporosis and 20% of men with osteoporosis will develop one or more osteoporotic fractures during their lifetime. And most people may think, hey, it's not that bad, but people don't realize the morbidity and mortality that comes with, in particular, a hip fracture and some of these larger fractures that these patients may come across. And very important is that osteoporosis is a silent disease. Patients don't know that they have it. It's something that needs to be aggressively screened. Sometimes patients may have a fracture, and that's what leads to their doctor to checking a bone density test, but it does not cause pain, and so that's why it's really important to be on top of screening. Who gets osteoporosis? So typically, it is more common in older, non-Hispanic, white, and Asian women, and it's much more common in women over the age of 50, particularly postmenopausal women. In the US, about 4.5 million women and about 1 million over the age of 50 have osteoporosis. So it's by no means a rare condition. So when does osteoporosis occur? And this is really important when we come to thinking about who we should screen. So in a healthy person, most people, their bones are the strongest in their mid-30s. And then after that, the bones start the bone strength starts, the bones start weakening, and our bones aren't able to replace it fast enough. And once a woman hits menopause, there's a precipitous drop in the bone mass. And for men, fortunately, it is a little later. It usually occurs around age 70 or so. So that's why we really like to have our postmenopausal females screened. Now, what causes osteoporosis? So it is, again, just due to the loss of bone mass and change in the bone structure. There are some risk factors that we like to take into account. Some that we could modify a little bit, and some that just can't. So patients at an increased risk, female patients of Caucasian or Asian race, these are risk factors that can't be changed, and they are risk factors, though, nonetheless. And patients who have a family history of osteoporosis, or if they've suffered a fracture in the past. And some things that, to consider that for lifestyle modifications, if patients smoke or if they drink more than 2 drinks a day, that does increase your risk for osteoporosis. Also, if you don't intake enough calcium or vitamin D. Also, patients with certain untreated endocrinologic disorders, or if they live a more sedentary lifestyle. And there also are some medications that we'll touch base briefly on, which can increase your risk for osteoporosis. And this is just a common talk. I'm not going to go into detail about this, but this is just important for us as rheumatologists, that every time we're evaluating a patient for osteoporosis, we really want to make sure that there's nothing else that's going on that is causing a secondary osteoporosis, meaning is there something else that's going on that may predispose you to have an earlier onset. And a big question that I always get is, does osteoporosis occur in men? And the question is yes, and that's with an exclamation point. The reason I say that is because I feel a lot of men aren't screened. People oftentimes think of this as a disease limited to women, but that's not true. About 1 to 2 million men in the United States do have osteoporosis. And fortunately, the diagnosis is the same. We use the same standard screening that we do for women. The only difference is that we begin screening in men later, and that's usually around the age of 70. And that's just because they start losing their bone integrity at a later age. One of the biggest differences, though, between osteoporosis and men is that most have some sort of identifiable cause that is causing their osteoporosis, whether it be some sort of long-term steroid use, hypogonadism, if they're, an alcohol abuse. The treatment usually and ultimately is the same. So how do we diagnose osteoporosis? So we do what's called a bone density test, also known as a DEXA scan or dual energy X-ray absorbitometry. And that is very similar to an X-ray. It's painless, it's very, very quick. And when a patient gets that done, and these can be done at a lot of facilities, a lot of imaging centers, a lot of hospital centers. We do them in a few of our locations as well. And when we look at this, what we're looking at is what's called a T-score, and that's what compares the patient's bone strength to that of a healthy person. And then it grades it into, is their bone normal, are they osteoporotic, or are they kind of in that gray zone, which we call osteopenia. Also, if a patient's never had a bone density test, but they've had a fragility fracture, that also characterizes them as having osteoporosis. And you may ask, what exactly is a fragility fracture? And that may be any sort of spontaneous fracture or any sort of very minimal trauma or loss or fall from a counter height that leads to a fracture, when things like that normally should not happen if a patient has strong, healthy bones. And another very important thing that we do as rheumatologists is every time we're evaluating a patient for osteoporosis, we want to make sure that there is secondary causes of low bone mass. So we oftentimes will check a lot of tests just to make sure that there's nothing else going on. So who should get screened for osteoporosis? These are just some basic national guidelines, and they refer to women over the age of 65, but we really recommend any postmenopausal female to get screened for osteoporosis. For men, that's over the age of 70. If you've had any sort of imaging and there's been evidence that you've had some sort of vertebral deformity or fracture, meaning if there's been a break in one of the bones in your spine, or if the X-ray is concerning that you may have thin bones, then you should go and get a DEXA scan or bone density test. If you have primary hypoparathyroidism, which is an endocrine disorder, also if you're on certain medicines, and the most particular for us as rheumatologists is chronic steroid use. Some patients may be on prednisone for joint issues, for respiratory issues, even for skin issues, and these patients who are on it for months should really be tested for osteoporosis. And then we do serially check our patients who are getting treated just to make sure that the medicines that we give them are working and are effective. So how is osteoporosis treated? We do have a lot of different medications that we do give. We have some oral medicines, we have some intravenous medicines, we also have a lot of injectable medicines, and these really come down to having a discussion with you and with the patient and their physician, and what other comorbidities or other medicines that you may be on. The most important things to take in is to make sure that you get enough calcium and vitamin D. The recommendations for calcium is about 1,200 milligrams per day. Most people consume about half of this if they eat an average calcium intake diet. So it is important to supplement. And most of the patients, particularly in the Midwest, do have a vitamin D deficiency. So that is something that we always check in our patients with osteoporosis. And they should be have adequate vitamin D levels. So we do recommend usually between 6 to 1,000 international units. Sometimes higher dosages may be needed depending on the severity of the deficiency. And weight-bearing exercises are extremely important for bone strength. So we do really encourage weight-bearing and strengthening exercises. And then modify any risk factors that you may have, whether that be tobacco or alcohol use. Easier said than done, but just some minor things that we can do. And preventing osteoporosis is very similar. We want to make sure that your lifestyle is adequate, that you get enough calcium and vitamin D, and you want to be physically active. So now we'll move on to the final disease that I'll talk about, and that's gout. So what is gout? So gout is a very, very painful form of arthritis. There also is a mimicker called pseudogout. Historically, it used to be called as the disease of the kings because it was thought to be due to overindulgence. Now we know that that's not the case. And then later on, it was actually thought to be a drop of evil that was affecting the joint. So in the medieval times, they would actually try to do bloodletting to hopefully get rid of gout. Gout is extremely prevalent. About 4% of the US population has gout, and that's just the ones that we know that are diagnosed. It is much more common in men as opposed to women. And the prevalence continues to rise. And one of the thoughts is that the most likely reason is as the levels of obesity increase, so does the metabolic syndrome, and gout oftentimes goes hand in hand with that. So what causes gout? So gout is caused by a crystal called uric acid, and what happens is that builds up and forms these crystals which can deposit in the joint and lead to those joint attacks. It can happen for a lot of different reasons. Sometimes we just don't get rid of uric acid enough, and that's most of the times our kidneys just don't work as well as they should. Sometimes we just make too much of it. And oftentimes there are certain foods and certain medicines that can increase those uric acid levels. And anytime that uric acid level increases, there is a chance for you to have a gout flare-up. The most common triggers that we see and that we counsel our patients on are particular some of these dietary changes. That's shellfish, red meat, the meat of animal organs, alcohol, and particularly food and drinks that are high in fructose corn syrup. Most patients don't realize how many of our foods in the U.S. do have fructose corn syrup, so that is really important to take into account. And there are certain medications that can also increase the uric acid levels. The most very popular one is low-dose aspirin, but on the contrary, we don't recommend stopping low-dose aspirin because the risks do, the benefits do outweigh the risks for maintaining that. Certain water pills can increase your risk and cause gout, and there are a handful of immunosuppressants that we use in transplant that can increase the risk. And what are the typical symptoms of gout? So these are very, very painful attacks of arthritis. They come on acutely, meaning they come on very quickly. Oftentimes they start in a single joint, and we usually think of the big toes, but it can affect multiple joints at once. The joints are often red, they're hot, they're swollen, and they're very painful. For example, if that happens in the big toes, patients often can't put on their shoes, or they can't even cover their foot with a bed sheet just because it's so tender. And over time, if gout goes untreated, it can lead to what's called tophi, which you can see in the photos on the side, and that is just that crystal deposition. And of course, anything that attacks the joint can lead to this chronic arthritis. And there are also, it's also known that gout can, especially in patients who have renal disease, can irritate the kidneys. So how do we diagnose gout? Ideally, in a perfect world, we like to have a joint aspiration where we take a needle and we try to get some of that fluid out to look at it. That is the most definite diagnostic test that we have. But oftentimes we don't have that pleasure, so we have to go off a few different things. There are certain patterns that patients may present with. They may hint at gout. In particular, if patients have what we call podagra, which is swelling redness of the big toe, that usually is characteristic of gout. We often do check other tests to make sure that nothing else is going on. Oftentimes gout is misdiagnosed as something like rheumatoid arthritis. That's why it is important to, to see your physician or to see a rheumatologist just to make sure that you're being treated for the right type of arthritis. We can check that uric acid in the blood. We do it very, very frequently. We use it more so for monitoring for our patients that we are treating with gout. And imaging studies, especially x-rays, are oftentimes very helpful, but we also do specialized CT scans or ultrasounds as well. And how do we treat gout? So we really look at treating gout in two separate ways. One is when we treat the acute flare, meaning if a patient comes in right away and their joint is red hot swollen. And the other one is chronic, is to make sure that we can prevent future gout flares. The acute flare-ups are typically treated with anti-inflammatories, colchicine. Also, patients sometimes may require corticosteroids, in particular prednisone or a Medrol dose pack. Oftentimes patients need a steroid injection. And recently, rheumatologists have been using a newer injection called anakinra for these refractory flare-ups. And there are certain home remedies that have been proven to work, and those in particular are cherry products, or cherry juice, and cherry supplements. And some patients ultimately do need, daily treatment for their gout, and we really take a look at who needs this. We recommend maintenance treatment for our gout patients, in particular in those who've had 2 or more gout flares a year. If their uric acid is very, very high, usually more than about 9, if they have evidence of crystal deposition, or if they do have kidney disease, then all these patients should really be considered for a maintenance treatment. And ultimately, the goal is to decrease those levels so our patients can be flare-free. And if they're flare-free, they're pain-free, and ultimately there's a less chance of damage to the joints. Then also dietary changes by addressing some of those triggers that I talked about earlier. And just some kind of key points. So don't be hesitant to see a rheumatologist. If you have any sort of joint complaints that you're not sure of, we're always here. And if you have a rheumatic disease, you're not alone. They're extremely prevalent. And most of these conditions are chronic conditions. There may not be a cure, but our goal is to have our patients living fully functional and oftentimes minimal pain or pain-free lives. And it's very important to get involved, to be physically active and to stay active in your own health and to be on top of it. And these are just some, resources that we refer our patients to. One is the Arthritis Foundation. The second one is the American College of Rheumatology, and then the National Osteoporosis Foundation. They do have great resources for patients. They have blogs. They have just, inside information into some of the treatments that we may use or therapies that you may like. So just something to keep in mind. That's all I have, and I'm happy to take any questions.
All right. Thank you very much, Dr. Sosenko. That was fantastic. We do have a few questions. This person asks, this is from William, do you have experience in diagnosing and treating Lyme disease? It seems to be the hardest systemic disease to correctly diagnose.
Yes, we do. As rheumatologists, we do that as one of the diseases that we do treat, and I agree that is a very difficult, diagnosis to come by a lot of the times. Oftentimes, we do need to check our patients multiple times for the Lyme antibodies, and exposure is often key, and some patients don't even know that they've been exposed in the past. So yeah, it is difficult, and that is something that we do treat as Lyme disease.
Great, thank you. Another question from Goldie is, when dealing with osteoarthritis, when do we see a rheumatologist versus an orthopedist?
So that's a great question, and I think, we oftentimes differ, on our approaches. The goal between, both rheumatologists and orthopedics is to, we'd like to, if we can, prolong there being any surgical intervention if it's not needed. So, both avenues typically will approach it the same way. We like to do conservative therapies, physical therapy, try some oral or topical creams followed by injections. And sometimes the pain is just too severe where, we're past that point, and that's, when the orthopedic evaluation would probably be the reasonable next step. But you can't go wrong with choosing either specialty.
Great,
and
thank you.
One other key is if you have arthritis of multiple joints, that is where a rheumatologist would be very beneficial.
Perfect, that's really helpful, thank you. Barb asks, does AS affect large joints as well as the spine? And I know you didn't go into, how do you pronounce it, ankylosing
spondylitis.
Yeah.
Yes, it can. Ankylosing spondylitis and any of the similar groups of diseases called spondyloarthropathies are known to cause large joint involvement, and that's kind of what differentiates it from some of the other types of inflammatory arthritis. It tends to involve the knees, even the elbows, etc. So it is a common cause.
Great, thank you. Cynthia says, what is the difference between psoriatic arthritis and rheumatoid arthritis?
Yeah, so they can appear very confusing. A lot of our patients, most patients with psoriatic arthritis typically have evidence of psoriasis, and that is an autoimmune type of skin condition. It is possible though for patients first to develop psoriatic arthritis followed by the skin disease itself. One of the biggest takeaways is the joint distribution is typically a little different. Sometimes it may mimic osteoarthritis, but it does cause a lot of, like rheumatoid arthritis, a lot of stiffness, a lot of pain, a lot of swelling in the joints. And patients may also have what's called nail pitting, which they can see some nail irregularities, and that is a very big telltale sign of psoriatic arthritis. A lot of these are treated very similarly though, but they are different entities.
And your rheumatologist could help you figure out which one you have.
Yes, correct. Yeah.
Great, thank you. Do I need a referral to see a rheumatologist, is what Raymond asks.
So it depends on your insurance. It depends on your insurance if you have an HMO or a PPO. So if you have an HMO, you typically need to get a referral from your primary care provider.
Great, thank you. And Jim asks, is undifferentiated connective tissue disease common? He didn't hear it mentioned.
Can you repeat that last part, Karen?
He said he didn't hear undifferentiated connective tissue mentioned. Is it common?
So undifferentiated connective tissue disease it's a loose term. It's when we're concerned about a lot of our diseases require specific criteria in order for a diagnosis of some of these autoimmune conditions. And that typically means that you fit a lot of the pictures, but we don't have all the puzzle pieces yet. I hope that answers your question.
Yeah, well, let's hope. Let's hope.
Yeah.
And I've got a few more coming in that I hadn't seen before, so I'm kind of bouncing around and I apologize.
Yeah, it's okay.
Joseph asks, is there any relief for RA using medical marijuana, possibly topical or edible?
So I cannot endorse or deny that, but we do have a lot of patients who do, who do use it. There hasn't been anything to support the use of it, but yeah.
Okay, thank you. And then Rebecca has a couple of questions regarding Prolia. She says the first question is, she has Prolia twice-a-year injections. Is it worth the risk of bad side effects of more aches and pains? And then she also asks, bad DEXA results, ellipsis, Prolia, question mark. So I'm wondering if she's thinking maybe the Prolia is giving her doctor bad DEXA results on her.
So Prolia is, when it comes to treating osteoporosis, we have a few different avenues to treat osteoporosis. Prolia is a very effective medicine. A lot of the side effects among any of the treatments we choose are similar, but a lot of them have certain, certain differences as well. If I think I'm addressing this question correctly, oftentimes we do reserve Prolia for some patients who have a little more advanced, osteoporosis. More severe findings, but ultimately if there's no improvement, I'm not sure if that's where the question was leaning towards, but if the DEXA scan is severe or worsening despite being on Prolia, then it is worth, meeting with your rheumatologist or your physician to see if maybe there is an alternative option. The biggest takeaway with Prolia is that it needs to be taken every 6 months. If you miss a dose, if you're a few months behind, you will effectively lose everything that you've gained. So that is a big takeaway point with Prolia. It works well when you take it. It works wonderful. It's usually very well tolerated, but one of the things to consider for the person who asked that question.
Great, thank you. Thank you. Okay, Linda is asking, how frequently can a bone density test be done? She's thinking it's only every 2 years.
So it really depends. Most of the times, if a patient has osteoporosis, and they're on treatment, we may do it anywhere from every 1 to 2 years, depending on their risk factors and what's going on. If they have osteoporosis, we typically don't do it any farther out than every 2 years or so. If you don't have osteoporosis and you're just getting screening guidelines and everything's okay, you can go every 3 to 5 years.
Got it. Great. Thank you. Raymond asks, is non-prescription Voltaren effective?
Yes, we think it is. And we really do encourage our patients who can take it to use it. It is an anti-inflammatory, and we're fortunate now. The United States actually, it did lose its patent, so now it's over the counter, whereas in the past it used to be prescription. But it is an anti-inflammatory, and if you do use it, some patients really swear by it.
Excellent, thank you. April asks, do autoimmune diseases develop into others? Is one prone to getting multiple autoimmune diseases if they've had one?
Yeah, and the answer to that is yes. If you have one autoimmune disorder, you are prone to getting another autoimmune disorder. And that could be anything if you do have, let's say, type 1 diabetes or Hashimoto's thyroid disease or something along those lines. You are at increased risk. And that's across the board for all autoimmune disorders. From a rheumatology standpoint, some of our diseases can sometimes kind of, slowly start morphing into other diseases. It's not so common though, but it is possible.
Okay, thank you. And then Naomi asks, if RA developed following the second Moderna vaccine, do you recommend the booster?
So, it's a tough question. We don't know enough about, the boosters and how they affect our autoimmune diseases. There is some thought in especially if you look at some of the, patients who have another type of autoimmune disorder called dermatomyositis, there is an association with patients developing, that autoimmune disease after certain vaccinations, particularly in children. No one knows. There is some thought that these patients who had an inherent risk to develop this autoimmune disease, and that was just kind of the cherry on top of the COVID booster or whatever vaccine it was just, the straw that broke the camel's back, that they would have most likely had some sort of, likelihood that they would have developed it later on.
Gotcha. So they should probably work pretty closely with their
Exactly.
rheumatologist
Yeah.
before making any decisions about any vaccines.
Yeah.
Got it. Great, great. Thank you. And then Naomi also asks, does IBJI have physical therapists or nutritionists that assist patients who have RA?
We do. Yeah, we have an ortho health. It's a whole clinic that we do that's dedicated to that. I mean, we do have physical therapists who are excellent, and we do have them in a lot of our different locations. But we do have dedicated, nutrition-led clinics.
Excellent. Thank you. All right. And I am looking and looking. Oh, and she said she lost audio. So April, you lost the audio. So hopefully you'll be able to watch this on the IBJI website or on the NSYMCA website later on. And let's see. Okay. Candace asks, how do you handle all the medication and injections and infusions? Can you run a risk of side effects or overdosage from all of the medicines? And I'm not sure what she's referring to. But
so we do monitor our medications very frequently. Most of the medicines that we give in particular for some of these autoimmune conditions do require serial blood monitoring. So sometimes it's every month, sometimes it's every 3 months. So we do take a look at that very closely. We do have some capabilities to check for actual drug levels. Most of the time that's not needed. The serial blood testing that we do is usually more than enough. That is something that we watch very carefully because we want to make sure that we're not causing any harm to the patient.
Got it. That makes a lot of sense. Great, thank you. And Catherine asks, do you ever recommend acupuncture for OA or RA?
Yes, for both.
Okay. All right. Excellent. Good, good. Let's see. Would you expect the flu shot to cause hand pain, including trigger thumb, which persists? Glenn wants to know.
Not typically. Oftentimes patients can have a lot of shoulder complaints after any sort of injection. They may get what's called bursitis, but not typically in the hand.
Okay. Okay. So it was probably triggered by something else.
Yeah.
Not the flu shot. Got it. And Barbara asks, would you maybe be able to say a little bit more about the difference between gout and pseudo-gout?
Yeah, so gout and pseudo-gout, the reason it's called pseudo-gout is because it often mimics gout, meaning these patients develop these acute or abrupt onset of arthritis. The joints are usually very red, very swollen, very hot to touch. Some of the biggest differences is that they're caused by different crystals. So gout is caused, in a scientific by uric acid crystals, whereas pseudo-gout is caused by something else. And the dietary triggers or some of these medication triggers that occur in gout, we do not see in pseudo-gout. So those are not relevant at all to pseudo-gout. Pseudo-gout is usually prevalent, more commonly seen in elderly patients, usually patients who have some sort of underlying osteoarthritis or have some sort of underlying thyroid or parathyroid or even kidney disease, et cetera.
Gotcha. Great, great. And then one last question from Rebecca. Do you know of the common side effects of Prolia?
So some of the common things that we have to watch for, we have to watch your some of your calcium levels. It's usually very well tolerated. Some patients may have a little bit of injection site reaction when they do take it. It typically doesn't cause a lot of the aches and pains that some of the bisphosphonates do cause. Any of these do cause an increased risk for what we call osteonecrosis of the jaw and atypical fracture. That's something that your primary care, your rheumatologist could talk to you more in depth about. But those are just some things to consider.
Great, great. Wow, we got through most of the questions. I thank you so much. I don't want to keep you late, but thank you for your time. Thank you for all of the great information. Thank you everyone who joined us tonight. This was fantastic, Dr. Sosenko. We really appreciate your time. Hope everybody has a great evening. We do not have a presentation in December, but please join us on January 26th at 7 p.m. Thanks, everybody. Good night, Dr.
Have a good
Sosenko.
Christmas.